Obstetric anesthesia. This is also known as the mother and the baby friendly obstetric anesthesia. It encourages the use of a regional anesthesia technique to keep the parturient in control during labor and delivery and experience the bonding and latch on with a newborn. Anesthesia for the vaginal delivery, epidural block, paracervical block, other anesthesia techniques for the labor and the delivery, saddle block, nitrous oxide with the O2 solution, IV narcotics and the sedative, now pharmacologic approaches. Epidural block. Initially dose is 7 cc of 0.125 BP vaccine or 0.1 percentage Ripple vaccine is administered after the 3 cc test done dose via the epidural catheter. Catheter is inserted at L3 to L4 or L2 to L3 intervertebral space. It could be gradually increase the concentration but not to exceed 0.25% for the bupivacaine and 0.2% for the ribavirin to avoid the motor block. Patient should know the obstetric epidural technique. Epidural anesthesia for the labor and the vaginal delivery. The first stage T10 to L1 bupivacaine. Explain the support. Second S2 to S4 T10 to L1 bupivacaine and ropivacaine is less than 0.20%. Paracervical block, first stage of labor and simple and the effective procedure. It blocks the uterine pain pathway at the pelvic genitalia. It is seldom used due to the possible fetal bradycardia. 5 to 10 cc of 1% lidocaine or 0.25% bupivacaine is injected at the fornices of the vagina. Pudendal block, second stage of the labor. It is simple and the safe, peripheral nerve, cost effective and easy to perform. Best done transvaginally. Fill up a 10 cc syringe with 10 cc of lidocaine 1 to 2% or bupivacaine 0.25% or ropivacaine 0.2%, 5 cc per side. Saddle block, second stage of labor, a form of subarachnoid anesthesia that blocks the sacral 2, 3 and 4 segments of the pudendal nerve indicated for the outlet force of delivery. Nitrous oxide with the O2 inhalation. O2 is 50 to 60% concentration via the face mask. In between the contraction, N2O is shut off and let the patient inhale the pure O2 to avoid the diffusion hypoxia. May be irritating to the airways. Now pharmacologic approach. LAMES, a prepared childbirth technique developed by the French obstetrician Dr. Fernand Lames as an alternative to the use of the medical intervention during the childbirth. Clinical hypnosis, the use of the altered state of consciousness for the therapeutic purposes. It harnesses the power of mind to heal the body. Acupuncture, it induces the labor contraction. Anesthesia for the cesarean section or the abdominal delivery. Subarachnoid block, epidural block, general anesthesia. Subarachnoid block, the most common and the preferred technique for the cesarean section, form of regional anesthesia that involves the injection of anesthetic into the epidural space at a predetermined location along the spine to produce the anesthesia in all the body regions that are supplied by nerve that arise below the anatomic region of the block. Epidural block. It is flexible, can be initially used in the control of the labor pain, produced by injecting the local anesthetic agent into the epidural space of the spinal cord at the first or second and the intercoccygeal space. General anesthesia. Indication for the general anesthesia, fetal distress, significant coagulopathy, acute maternal hypovolemia and the hemodynamic instability, sepsis or the local skin infection, failed regional anesthesia, maternal refusal of regional anesthesia. Maintenance of the general anesthesia. Pre-delivery, 50% 0 O2, 50% of N2O, 0.5% isoflurane, 100% O2, 1 to 1.5% isoflurane. Post delivery, 50 to 70% of N2O, 30 to 50% of O2, 0.5% of isoflurane narcotics. Minimize the volatile agent to prevent the postpartum hemorrhage. 0.5 MAC does not significantly increase the maternal blood loss. Emergence from the general anesthesia, stomach emptied via an OG tube. Upper airway suction, non-depolarizing agent reversed adequately. Opioids for the pain relief. Extubation when the patient retains the protective reflexes or able to maintain the airway, respond appropriately to verbal commands and are hemodynamically stable. Fetal consideration during the emergency cesarean section. Decision to incision or the interval 30 minutes. Uterine incision to delivery interval should be less than 3 minutes. Neonates delivered after 3 minutes following the uterine incision had lower APGR and acidotic blood gas. Anesthesia for the labor and the delivery. Anesthesia to alleviate the pain of pain of the childbirth is unknown before the middle of the 19th century. In 1847, Dr. James Young Simpson of the Edinburgh was able to use diethyl ether as a general anesthesia. In 1900, Oscar Kreis from Switzerland was the first to recognize the advantage of the general anesthesia in regional anesthesia in obstetrics. In 1980, Society for the Obstetric Anesthesia of the Philippines was created to promote and uphold to the provision of safe, pain-free to the Filipino mother. Update the knowledge and the techniques in the obstetric anesthesia. Dr. Alfonso Duladroso is founding the president. Now we can go for the physiologic changes in the pregnancy. Cardiovascular system. The cardiac output increased by 30 to 40% most rapidly in the second trimester. Immediate postpartum period, cardiac output rises maximally and can be 80% above the pre-labor values. Clinical implication. Increased cardiac output produces a hyperdynamic state which increases the cardiac workload. Predisposes to the development of the functional moment. In gravidocardiac increase the work in the heart adds the strain may precipitate the pulmonary congestion, especially during the labor and the postpartum. As I said before, in the cardiovascular system, increased cardiac output produces the hyperdynamic state. In gravidocardiacs, they increase work in the heart that adds strain, may precipitate pulmonary congestion, especially during the labor and the postpartum. Continuous epidural analgesia, they used to prevent further increase in the work of the heart in gravidocardiacs during the labor. Blood volume changes. The maternal blood volume rises during the pregnancy. This involves a plasma volume increases by 40 to 50%. The red cell volume increases by only 15 to 20%. This leads to the physiologic anemia of the pregnancy. Clinical implication. A physiologic anemia of a pregnancy is a double-edged sword. Increase in the clotting factors offer the protection to the parturient. The hypercoagulable state may increase the risk of the thrombotic events. Dr. Keval syndrome. Meg Roberts in 1951 the first to suggest the etiology of the arterial hypotension in the supine position. In supine, the uterus compressed against the vertebral column, impairing the return of the venous blood from the lower limb and the pelvis to the heart. This causes a symptom of the bradycardia and drop in the blood pressure in about 8% of women. Supine hypertensive syndrome results from the drop in the venous return for which the cardiovascular system cannot compensate. Condition that predispose to the particularly large uterus, multiple gestation, polyhydramnios, diabetes mellitus. These parturants are susceptible to the arteriocaval compression. Factors reducing the CSF. Engorgement of the epidural veins secondary to diversion of blood consequent to venous compression. Internal vertebral venous plexus. This is engorged and the capillary circulation of the meninges slowed down. Progesterone. This is mediated sensitivity to the anesthetics. Reduced CSF protein concentration, thus the movement of the anesthetic across the neural membrane is slowed. Respiratory system. The vascularity of the respiratory tract mucosa increases and the capillaries engorge. Frequent upper respiratory tract infection is common. Edema of the airway may be aggravated by the voluntary and the involuntary Valsalva maneuvers. Clinical implication: the women risk for the difficulty in the airway management should have her airway assessed periodically throughout the labor. For example, the pregnancy-induced hypertension and the preeclampsia. Mucous membrane are friable, especially in the third trimester. Careful manipulation should be done as the severe bleeding may occur. Difficult intubation and need for the small diameter of the endotracheal tube should always be considered. Risk of the general anesthesia, wherein failure to secure the airway should be considered. Respiratory mechanics: upper displacement of the diaphragm leads to the decreased functional residual capacity. Increase in the minute volume approximately 50% above the non-pregnant values due to the increased tidal volume, lesser extent due to the respiratory rate. Clinical implication: induction of the anesthesia faster due to the decreased FOC and increased the minute volume. Inhalational analgesic requirement decreased during the pregnancy. There is a risk in aspiration due to the rapid loss of fluxes. There is predisposition to the limited oxygen reserve. This may cause the hypoxemia and the hypercarbureting during the periods of apnea. Secondary to decrease the FOC and increase the oxygen consumption. This pre-oxygenation prior to the induction of the general anesthesia is imperative. Prolonged laryngoscopy should be avoided. Gastrointestinal system: progesterone is elevated, decrease gastric motility, decrease the food absorption. Gastrin is elevated of the placental origin, increase the gastric acid contents. Enlarged uterus increases the intragastric pressure, decrease the normal oblique angle to the gastroesophageal junction. Clinical implication: the pregnant patient always considered to have the full stomach irrespective of the last meal. General anesthesia should always be avoided as possible due to the risk of aspiration. Incidence of the aspiration in the obstetric ranges are 1 by 10,000 to 15 by 10,000 and highest in the caesarean section than in the other obstetric procedure. Pain in the annexity narcotics serve to further retard the gastric emptying. Secure airway immediately in case of general anesthesia used. Non-particular antacids may decrease the acidity of the gastric contents and the augment gastric emptying time. Example: sodium citrate, metoclopramide. Pain mechanism in the labor: the first stage of labor, they arises from the uterus and annexine, mediated by T10 to L1 spinal segment. The pain is brought about by the dilation of a cervix, lower uterine segment, and their subsequent mechanical distension, stretching, and the tearing during the contraction. Pain intensity is related to the strength of the contraction and the pressure thus generated. Pain is visceral in nature, characterized as dull, diffuse, periodic, and builds to peak. Second stage of labor, the pain results from the distension of the birth canal, vulva, and the perineum. They are mediated by the afferent nerves of the posterior roots of the S2 to S4 nerves. Pain is more somatic in character and is usually well localized, sharp, and definitive, and often constant. In order to provide the satisfactory analgesia during the labor and delivery, this pathway should be blocked. Anesthesia for the labor and the delivery. The epidural analgesia. Gold standard for the labor pain relief. Disadvantages like financial cost, require complex adjacent care, possible undesirable side effects, and the alteration of the labor pattern. Now, pharmacologic methods of pain relief. Can you close the Non-pharmacologic methods of the pain relief: childbirth education, LAMIS, mind-body intervention, hypnosis, biofeedback, music therapy, bioelectromagnetics, transcutaneous electrical nerve stimulation, intracutaneous nerve stimulation, sterile water blocks, acupuncture. Manual healing comes under therapeutic touch, massage therapy, muscle tension release, reflexology, acupuncture system, and hydrotherapy. While speaking about the herbal medicine, herbal cocktails, aromatherapy. The pharmacologic methods of the pain relief: the first one is opioid. They provide the partial analgesia, maternal side effects, nausea, vomiting, delayed gastric emptying time, dysphoria, drowsiness, and the hyperventilation. They can cross the placenta easily. Secondary to being lipid soluble and have the low molecular weight, they can lead to the risk of the neonatal respiratory depression and the neurobehavioral changes. Sedatives and or tranquilizer. Phenothiazines, they can be used to allay the apprehension and the anxiety in conjugation with the narcotics to decrease the incidence of the nausea and vomiting. Phenergen, the common system analgesia used as an infant, which is the combination of the Dimafol 50 mg and the Phenergen 50 mg given the intramuscularly. Benzodiazepine, pure sedative drug with no analgesic effect, anxiolytic, amnesic of the anticonvulsant, diazepam and the midazolam. Diazepam, drug of choice for the convulsions following the local anesthetic toxicity or in the eclamptic patients. In small doses, they did not affect the APGA scores. In large doses, they can produce the neonatal hypotonia, lethargy, and the hypothermia. Sodium benzoate used as its perfect candidate to the displacing bilirubin, thus hyperbilirubinemia in the newborn. Other drugs used is the ketamine, dissociative medication, induction agent during the general anesthesia can lead to the delirium and the hallucination in the large amount. Increases the intensity in the uterine contraction has been observed. Barbiturate, seldom used in the first stage of labor. Thiophental, used just prior to delivery and of the infant, the crowning stage, and provides a pain relief for the epistomy. Propofol, new drug, milky white in appearance, substituted isopropanol, a derivative in the 1% of a solution. Sedative hypotonic effect through the interaction with the GABA receptors. They provide the smoother induction of the anesthesia and does not have the anti-analgesia properties. Drawback is pain during the injection. Inhalational anesthesia, all volatile agents that causes a dose-dependent relaxation of the smooth muscle. They may decrease the uterine smooth muscle response to the oxytocin. Uterine atony become a risk. Limit of use of the inhalational analgesia in the first stage of labor. The need for the specialized vaporizer, incomplete analgesia, potential loss of protective air reflexes, and the pulmonary aspiration of the gastric content. Indication of the high concentration of the inhalational anesthesia necessary to relax the uterus for the manipulation by the obstetrician in case of the manual extraction of the placenta, extraction of the after coming head during the breech delivery, internal version, and the extraction of the second twin. Peripheral blocks for the labor analgesia, peripheral infiltration, most common local anesthetic technique for the vaginal delivery, mainly for the epistomy and the repair, supplement pudendal blocks and the unsatisfactory epidural anesthesia. Lidocaine, they are commonly used. Pudendal nerve block, they inject 7 to 10 ml of the local anesthetic to the right and the left pudendal nerve as it passes medially and posterior to the ischemic spine in the each side of the pelvis. Two routes, transvaginal and the transperineal. Paracervical block, injecting 10 to 20 ml local anesthetic in the paracervical tissue in the right and the left vagina fornices. Block the transmission through the paracervical ganglion known as the Franklin's ganglion, lies immediate lateral and the posterior to the cervico-uterine junction. They provide analgesia for the first stage of labor. Common distressing complication is the fetal bradycardia. Neuraxial block, they provide the most effective and the least depressant form analgesia for the labor. Types: epidural anesthesia, combined spinal and the epidural, saddle block. Drug used: bupivacaine, most commonly used. Ropivacaine, recently introduced locally, has a wider margin of safety in cases of the intravascular injection, less motor block, less cardiotoxic. Levopubicaine, new drug only used in the US. Saddle shock, the modified spinal block, administered minimal dose of local anesthetic, 4 to 6 ml of the tetracaine 15 or bupivacaine 0.5% intrathecally. Common technique used for the second stage labor is the saddle block. This affects only the sacral segment. They provide the complete pain relief caused by the perineal distension and ideal for the completion of the second stage of labor. Other pain relief method: intravenous of the epidural, patient controlled analgesia slowly being transduced. In a country, parenteral opiates or the epidural mixtures of the local anesthetic can be titrated via the PCA pumps operated by the patient herself to provide the modest analgesia and the good patient satisfaction. Main drawback is the cost of PCA pumps. Anesthesia for the cesarean section, the most common anesthetic technique used is the regional anesthesia. Two common regional techniques: spinal or the subarachnoid anesthesia. These are more common. simpler, more reliable with a lesser chance of failure, faster onset of action. Epidural anesthesia. Regional anesthesia preference due to the mother remain awake and is able to bond with the newborn upon the delivery. Intact the pulmonary reflexes decreases the maternal risk of the pulmonary aspiration of the gastric contents and the decreased Mendelssohn syndrome. Common complication is hypotension, post-dural puncture headache, use in the cesarean section as the limited indication, failure to ventilate and secure the airway is leading cause of the mortality in the general anesthesia. Thank you.